Dr. Aman Sharma sir, Professor of PGI Chandigarh, to begin the session of Clinico-Pathological Conference. Dr. Aman Sharma sir would be the facilitator for the CPC. I would also like to invite Dr. Anand Malviya sir, Head of the Department of Rheumatology at ISIC, New Delhi. Dr. Malviya sir will be the chief moderator for the CPC.
We are already behind the schedule, so without any further ado, I will request my colleague and very close friend and a great rheumatologist, student, okay, Ramnath Mishra, kindly go through the CPC protocol and then give your discussion, and then we, if time permits, we'll have question answers.
How to change slide? Yes, sir. Thank you, sir.
Yeah, sure.
I have captured the protocol through a set of slides which I go over you. You can match that with the protocol you have in hand. This 28-year-old lady who was, this was the last admission, 21/10/2020, and date of death was 29. There is a little printing mistake in the protocol, the date. One is 20 and another was 21. Aman, can I just make a correction? I think she could not have been admitted for a year. To start the story, 2014, she was first detected to have ITP and treated with steroid. Then in May 2019 to July 2019, she was diagnosed to have abdominal TB because of fever, pain, pyoperitoneum, ascitic fluid AD of 81, PPD was negative, and she was treated with ATT. We are not sure how long she took ATT, but with it, she was also diagnosed as SLE, and she had a number of features which highly suggestive of SLE, that is malar rash, oral ulcers, photosensitivity, alopecia, myocarditis, ANA positive, and low complement C3 and C4. She was treated with methylprednisolone for 3 days and possibly oral steroid, but we don't know the dose or how long she took, and hydroxychloroquine. Again, in the same year, 5th of August, she had a lupus flare with mucocutaneous hematological serositis, nephritis, and myocarditis with considerably high dsDNA. In our center, the upper limit is 100. I believe 379 could be very high. Low C3, C4, and a 25 urine protein in the nephrotic range. She underwent a kidney biopsy, which was class 3 and 5 with activity index of 4/24 with no chronicity index. And she was treated with IV cyclophosphamide, 6 dose, and the last dose was 13th, and then she was lost to follow-up. She resurfaced in September 20 and was admitted till 5th October, And she had again facial and bilateral low limb edema for 25 days with heavy menstrual bleeding. And on evaluation, she had anemia, iron deficiency, chronic disease, thrombocytopenia, proteinuria rising up to now 12 gram, and serum creatinine was normal. She again had low C3, C4. The direct Coombs test was negative, and antiphospholipid antibodies were negative. This time she was treated with prednisolone and MMF 1 gram daily, and proteinuria on 3rd October was 3 gram. So it was a steroid responsive proteinuria, of course had active SLE. The final admission was done 15 days later on 20th of October, and she lasted for 9 days. This time the presentation was shortness of breath, orthopnea, palpitation, decreased urinary output, swelling of the left lower limb. The general condition was fair. Pulse rate was high. She had BP and a respiratory rate of 30 per minute. The saturation of oxygen was 96%. She had oral candidiasis, anasarca, and bilateral crepes. Both the heart sounds were normal, and abdomen-wise, she had per abdomen a surgical scar present, soft, non-tender, no organomegaly, bowel sounds are present. These are the serial blood test result, and one can see at presentation the hemoglobin was 6.7 with a raised TLC count, a platelet of 74, and a creatinine of 3.46 with potassium of 7.7. And as you can see through the serial results, almost daily, the hemoglobin hovered around that level. The TLC count increased to 20,000, then 17,000. The platelet count, again, up till 23rd, there was a dip in the platelet count, and then terminally it was back to 90-100. She had very low albumin, 1.9, 1.8, 1.9, 1.7 on 4 consecutive days, and the creatinine was elevated almost throughout. Her procalcitonin was 6.5, that's very high, and it remained high, and in 25th it was 100. The pro-BNP, a marker of cardiac damage, was very high, 30,367, 25,000, 26,000. And the APTT was abnormal towards the end. The fibrinogen was okay, but the D-dimer was high on 23rd and 25th till 25th. She was negative for APLA. The complements level is normal, no hypocomplementia. She was negative for blood culture and urine culture, as it usually happens when we have septicemia, sepsis, but the blood cultures or urine culture are usually negative. The hemoglobin A1C is 5.5. The thyroid function tests were normal. This is the blood gas serially, and in fact, there was a metabolic acidosis from the beginning with a base excess of minus 7.2, and she was given NIV with FiO2 of 0.5, which increased to 0.9, 0.5, 0.6, and towards the end it was FiO2 was 0.9. This information has been given, and these are the chest X-ray. You see floppy shadowing mostly in the middle zone, lower zone, and 2 days later, we see the dense shadows now, and now she was intubated here, and you can see subcutaneous emphysema, which have been mentioned, and this was the pre-terminal. I can't see the tube here, but I believe from the date that this was 1 day later. Other investigation that we have provided, that her echo on 24th and 26th, the ejection fraction came down to 25 to 30%. The ultrasound abdomen had moderate ascites, but the screen for DVT was negative. On the very first day of this last admission, she was hemodialyzed, and here she was positive for COVID-19, which was repeated on 25th, 4 days later, and it was negative. Non-invasive ventilation for respiratory failure. She was given piperacillin, tazobactam, dexamethasone, and MP bolus. On 25th 10, mechanical ventilation was given. MP was given. I must say that someone was bold to give rituximab. But she had worsening respiratory failure, injection colistin was added, profuse bleeding through ET tube, and she succumbed on 29th. So it's very obvious she had SLE, she had nephritis, hematological feature, persistent thrombocytopenia, and myocarditis with COVID pneumonia and biventricular failure, and acute kidney injury in the last admission. And probably the most significant contribution death was the cardiac failure. Other pointers, there are biomarkers for cardiac failure. She had very high pro-BNP, thrombosis, and bacterial infection. So a number of things. Let's analyze. She definitely had SLE activity. 2 weeks ago, compliance was an issue with her probably. There's no medicine has been mentioned between the last discharge and this time. And her C3, C4 are normal. Leukocytosis, procal, CRP raised, all points to a bacterial infection. The chest X-ray could be explained by SLE pneumonitis or diffuse alveolar hemorrhage. But diffuse alveolar hemorrhage, usually we see a more homogeneous pattern than this. So my preferred diagnosis was present SLE and a bacterial infection. We always think of thrombosis even during the HIV period. So there was, the D dimer was high. There was, the against was, there was no evidence of DVT or ultrasound Doppler, no MI on ECG or echo. TTP I don't consider. She didn't have any cystocytes which have been mentioned. So which infection? COVID for sure. whether it was COVID alone and that COVID could have caused the myocarditis, but her procal was very high. So I am tempted to think that it was a bacterial pneumonia, high procal with neutrophilic leukocytosis, but of course will not explain a culture negative. Mycobacterium we always consider because in the past she had TB and fluffy opacities on chest X-ray. They didn't look like a TB this time. I thought it was more bacterial. Always we are surprised in CPCs of fungal pneumonia. We think of something else and something else comes out. So I thought maybe the card they have in their pocket is that of a fungal infection. She had oral candidiasis in the past, but the high procal prevents me in making a logical fungal infection. The cause of cardiac failure is SLE myocarditis. COVID myocarditis is rare, or a multi-inflammatory syndrome in adults have been described, but it usually occurs 3 to 4 weeks after COVID. We don't know when she picked up the COVID. I would stop here, sir.
Okay, so can we have the last slide, please, so that we know what is Professor Mishra's diagnosis? Please do let the slide be on this screen. I will then request the treating physician, Professor Aman Sharma, to give his story of what did he think of, what was the treatment based upon what hypotheses, what possibilities.
So basically, this patient was initially admitted under us and then was shifted to the COVID facility. The toss-up was we had active lupus, we had COVID positivity. The only toss-up was whether and to what extent the manifestations are because of SLE and what are because of COVID per se, because as has been discussed, both the lung involvement, the heart involvement and various other manifestations can occur in both. So that was the key. I think that's what was done and has been managed, has been reported in the protocol also. Probably maybe we can have opinions from about diagnostic possibilities. One thing is that this is just a clinical diagnostic forum, so not management issues. So if probably I would...
So in short, was it lupus and its complications? Was it more of COVID and related complications? Or a third possibility that we are missing somewhere? I will request, because the time is short, precise questions or possibilities that our colleagues may like to mention, but in brief.
Which was negative.
Negative. Negative, that
twice.
was mentioned.
Yes, sir. CMV, cytomegalovirus.
Mishra, cytomegalo. Baithe raho, baithe raho.
They usually have pancytopenic picture. This lady was having a neutrophilic leukocytosis on day 1, day 2, day 3. So therefore, I wouldn't consider CMV. I didn't consider CMV.
Any other possibilities? Can you take the mic? I can't hear you.
BAL was not done. The patient was in the COVID facility. So the BAL that was there was not possible.
Mike.
You can come up while the question is...
Sir, actually I had a similar patient like this, was admitted around 3 months ago with my facility, and the patient had a similar presentation with a myocarditis patient.
Your possibility, please.
What is the possibility in this
Your
case?
diagnostic possibility.
Sir, we found the nocardiosis in the biopsy in the intestine.
Okay, so nocardiosis.
Right.
Yours?
Sir, this patient had low globulin levels, so CVID was considered, which could have caused secondary infections also, leading to this.
So you think all the manifestations, even a priori for those many years, were all because of an immunodeficiency?
No, sir, SLE could have coexisted with CVID. Autoimmune manifestations are known to occur.
Can we now request the pathologist to enlighten us and prove who is right and who is wrong? The verdict from the Supreme Court.
Thank you, sir. There's no verdict. I think I'll just demonstrate what we saw and just try to dissect out, like we always try to dissect out in a multisystemic disease what could have been caused by what, but let's see how far we are able to do that. So in this young female, can I have my slides please? A complete autopsy was done, which means brain was also examined. The different cavities were examined. There was some fluid in the pericardial cavity, which was 30 ml and hemorrhagic, and in peritoneal cavity also there was about 1 liter of fluid. So let's start with the kidneys. So as we see here, the kidneys were normal in size. They were slightly overweight. On gross external examination, they are normal. There are no focal lesions to say that there is no infarct. On cut section also, we do not see any evidence of any focal lesions. There is the cortex is well maintained and there is a distinct corticomedullary junction. So at a low power, what we can make out is that these round things which are glomeruli, all of them seem to be involved, which goes to say that it appears to be a class 4 lesion in a lupus, case of lupus. And when we try to look at what kind of proliferations were there, you see endocapillary proliferation, we see extracapillary proliferation in the form of crescents, which were present in more than 70% of the glomeruli, and as well as what we see is these kind of basement membranes which were quite thickened, and which on these kind of lesions which we call wire loops. There is some neutrophilic debris and there were some neutrophils which were also present there. So these are just some of the features which I am trying to point out, which are markers of active lesions. So there is wire loops, there are neutrophils, there is neutrophilic debris and crescents. Another picture to show that these wire loops were present in many of these glomeruli. So say this is very peculiar of lupus nephritis, that you can have all kind of lesions in the same glomerulus. So you have wire loops, extracapillary proliferation and as well as endocapillary proliferation in the same glomerulus. These are the wire loops, but in addition, if you see on a closer examination, you see that this basement membrane is quite thickened like this without any subendothelial component, thereby indicating a component of class 5 being also there. Some of the glomeruli shows mesangiolisis, which is a manifestation of thrombotic microangiopathy. This is a Masson's trichome stain which highlights a degree of chronicity here. You can see there is interstitial fibrosis which is in the form of this green color which is seen in the interstitium. Also some of these crescents were old because there is a green color, that means they were fibro or fibrocellular in nature. So this is just to show that there were both glomerular as well as interstitial scarring. So this is of some duration. Blood vessels were examined, arteries are normal, there were no evidence of thrombosis or any arteritis in these arteries which were examined, and no immune deposits were seen on microscopy. Microscopic examination, we see a full house pattern with all the immunoglobulins being present, C3 and CV1q being present and both the light chains being present. So it's a full house pattern in a proliferative lesion which is class 4 lupus nephritis, along with the component of membranous, because you could see a granular staining pattern along the capillary loops as well. On subtyping, it was mainly IgG1 subtype which is seen. So thereby further confirming that it's an immune mediated condition and you see these kind of granular deposits along the membrane to say that other than wire loops, there was coexisting membranous. Though the arteries which I showed were normal, they had these deposition of immunoglobulins, which means there were uncomplicated immune deposits within the blood vessels. So this was what we had as far as lupus nephritis was concerned. And when we did the activity scoring, keeping these parameters in mind, the total score comes out to be 12 and a chronicity score comes out to be 14. So this is a class 4 plus 5 lupus nephritis with uncomplicated immune deposits in the vessels, with the activity score of 12 and 4 as against the previous biopsy which we mentioned during the protocol. As you see in this biopsy, there are only these some areas of proliferation being seen. So that means at that point of time the proliferation were not class 4, rather they were only in less than 50% of the glomeruli, only in the form of endocapillary proliferation, no crescents and no crescents and no wire loops. So at that point of time the activity was only 2 and there was no chronicity. So there was change in class, there was a lupus flare in terms of kidney disease, and the chronicity has progressed. So this was a progression of activity and chronicity in this as far as kidneys are concerned. Now coming to heart, as Sir mentioned, there was pro-BNP was quite high. As you see, this heart weighed 330 grams, which was normal for this age. On opening chambers, we did not find any evidence of any endocarditis, mural or along the valves. Everything was normal. The blood vessels, the coronaries were dissected and they were also patent. There is no evidence of atherosclerosis. There was evidence of pericardial inflammation and fibrosis, that means there is pericarditis as seen as fibroblast, and within the myocardium you see there is separation of these myocytes by this edematous edema as well as inflammatory cells being there. These are the blood vessels which I shall show you again. The myocytes are showing you evidence of degeneration, as you see. If this is something normal, so you see the evidence of degeneration in many of the myocytes along with accompanying edema, which means an early change and some early inflammation which seems to be there. So there is evidence of myocarditis. The blood vessels, when we seen, the endothelium is prominent, but there is no immune deposit seen grossly on microscopic evaluation, and there are no thrombi which are seen. There is no evidence of thrombotic microangiopathy. But on immunofluorescence, we do see presence of IgG and IgG within these capillaries which were present within the myocardium, and some of the myocytes were non-specifically binding with this IgG. So which means probably this myocarditis is due to immune-mediated vascular component, immune-mediated injury rather than being of viral origin. So that is how we concluded that at least this myocarditis seems to be lupus associated, not because of COVID. The brain weight was normal. There was no grossly any abnormality which was seen. However, on microscopic evaluation, there was edema in the form of perineuronal edema and presence of some perivascular hemorrhages. Within that, we did not find any grossly abnormal blood vessels. There was no thrombotic microangiopathy or vasculitis which was present. There were multiple such areas, and on immunofluorescence one could demonstrate presence of immune deposits here, thereby meaning that this brain changes were because of lupus vasculopathy rather than being due to thrombotic microangiopathy or any coagulation related issues which can happen in a COVID situation. So again, this was probably because of lupus vasculopathy, as was probably in a paper on autopsy series of lupus was shown in one of the previous sessions. So now coming to lung, which again was one of the points of discussion. So lungs, as you see, were overweight. They weighed around 1 kg, and on outer surface we can see that these are some blackish areas of discoloration, and they were present on both the sides. On cut section you can make out that this is relatively normal area, and largely the lungs are hemorrhagic in color, and there were some areas which are relatively different looking as compared to these hemorrhagic solid areas. They were look at these areas which are rounded and they are purely reddish. They were more softer than adjacent areas like this. These blood vessels were examined closely to look for any evidence of thrombosis, which was not found in these. So this is a scanner view of those blackish localized areas, and as you see, these areas are just but not a pool of hemorrhage. There's nothing seems to be here, and these areas seems to be relatively solid. In these areas, as you see there is widening of these septa, and those hemorrhagic areas had more of just fresh blood. There is presence of edema within the alveolar spaces, which is pale, so there is alveolar edema. There were evidence of fibrin thrombi in other areas within the alveolar spaces. Type 2 pneumocytes were prominent, and there were some of these capillaries which were having this kind of fibrin thrombi which were getting organized, and there was this kind of expansion of alveolar lining and diffuse alveolar damage which was lining these membranes which were lining these alveolar spaces, thereby meaning that there is evidence of diffuse alveolar damage, which is a counterpart of ARDS. So here we see fibrin balls, and this is the hyaline membrane which lines these alveolar spaces, which are almost completely obliterated. So this was a cellular phase of diffuse alveolar damage. The bronchi did not show any cytomegalovirus or any other fungus. The only this rich mucin was seen with some inflammation. So in these solid areas of lungs, what we had was diffuse alveolar damage in an exudative phase. Now coming to the areas which were much more hemorrhagic, like these ones, in these areas on a closer examination, what we found was there was evidence of inflammation within the alveolar capillaries. There were neutrophilic debris here and some this pinkish material which is fibrin, which means there was capillaritis, evidence of capillaritis in these particular areas, which were resulting in shedding of this fresh RBCs into the lumen, though bigger arteries did not show any evidence of thrombotic events. Here again you can see evidence of endotheliitis in one of the relatively bigger arteries. Immunofluorescence again was just to kind of dissect out whether it is COVID related or immune mediated. So here we see this is IgG stain, and you see this is the alveolar septa. We see these capillaries, and these capillaries do show presence of immunoglobulin deposition, thereby indicating that possibly this kind of a capillaritis is being mediated by, it's an immune mediated capillaritis. And C4D was also positive, which is again a marker of being classical complement pathway activation, which is likely to happen in a case of lupus pathology. So here what we had was diffuse alveolar hemorrhage with deposition of immunoglobulins and C4D in areas of capillaritis, thereby indicating a presence of lupus pneumonitis in a background which of diffuse alveolar damage, which was probably COVID related. So here we did submit various tissues for PCR for SARS-CoV-2 virus, and it was found to be positive. The patient was negative on serology, on PCR testing on blood, but the tissues which were sampled, they did show positivity. Lung was positive. I shall show you some more. Immunohistochemistry for SARS-CoV-2 was also done, and within these areas, lungs, the cytoplasmic positivity of this virus was demonstrated. So definitely some component of this lung pathology was due to SARS-CoV-2 virus, and in addition I have showed you immune mediated damage in some of the areas, in other areas, in hemorrhagic areas. Now coming to liver, pancreas and spleen, they were grossly normal. Liver did not show any abnormality, there was no fibrosis. Spleen, however, showed depletion of white pulp. There were no blue cells here, so there was lymphodepletion, as was confirmed on immunostains for CD3 and 20. And splenic tissue submitted also was positive for SARS-CoV-2 virus. Lymph nodes showed evidence of hemophagocytosis and lymphodepletion. These are the macrophages with RBCs engulfed. There was lymphodepletion as confirmed by these stains, and this lymph node, however, was negative for virus. The GI was grossly and microscopically normal. And the virus was tested here also, which was negative. Stomach is negative. Skin did not show any changes, and IF was negative, so there was no lupus band test. The uterus and these were examined. There was adenomyosis and a splenic, there's a cyst on the outer aspect of this. Muscles, thyroid, adrenal, they all were normal. So summarizing our finding in this case, we have tried to dissect out the changes which were because of lupus and changes which were because of SARS-CoV virus. So at autopsy, we kind of confirmed that the lupus nephritis flare was there, as there was increase in activity from class 3 to 4 along with class 5 being there. Lungs had evidence of lupus pneumonitis, which was confirmed by evidence of immune activation there. There was lupus myocarditis and pericarditis, and brain changes because of lupus vasculopathy resulting in microhemorrhages. There was an element of diffuse alveolar damage in an exudative phase, which was likely due to SARS-CoV virus. There was hemophagocytosis, again, which could be virus induced. There was marked lymphodepletion. The patient has been treated quite a bit, and maybe some component could be because of this virus being there. Hemorrhagic cyst and organizing serositis was there in the intestines, and uterus showed adenomyosis. So this is what all we had in this case, and for this I really thank my whole team, especially our residents of pathology who went and did the autopsy in COVID period where our facilities were not really that up to the mark for to deal with this kind of an infective state. So however, they went ahead and did the autopsy, which was very good of them, and our treating team, which had put on a lot of efforts for getting the autopsy done. Thank you, sir.
Thank you. Thank you, Dr. Nada. I think I will have to congratulate Ramnath Mishra. He got the whole thing on the dot, that this was primarily manifestation of systemic lupus with complications in several organs overlapping with SARS-2 infection, and some of the features in the autopsy clearly showing its presence, and due to it the changes in the tissues. I will like, in case you can make any other comments and your final.
I thought you congratulated more than what I deserve, because I was thinking that it was because of the raised CRP, ProCal, it was a complication of bacterial. I knew it was COVID, that was for sure, but the COVID damage, all with active SLE, can explain the death.
My own, just one comment is that shows clearly that our patients who disappear and resurface after some time, especially in lupus, they are in trouble. And in those cases, it's lupus mostly that is causing the main problem. Aman?
Yeah, I think there was a good clinico-pathological correlation, as we say. The pointers which were taking us away clinically from it being COVID were that in the various cohorts, including the NEGM publications and our own data from PGI, the anemia and hematological manifestations, unless they end up with HLH kind of presentation, is not there in COVID per se, but it was dominant in this patient, as were the other manifestations which were highlighted. So the dilemma always in a treating physician is, which was being discussed just in the preceding session, how much of the clinical presentation is because of infection in the presence of overwhelming evidence of disease activity. I think we sometimes can tease out, sometimes we can't, and that enigma also continued in the discussion that we've had. And I think we've had a good clinico-pathological correlation. That's all that I would have to say.
I think I'll call it the session, because we are short of time and the next sessions are starting in the other halls. Thank you, everyone.